Afternoon.
Good afternoon.
My name is Dr. Rhoda Kalondo from Kenyatta National Hospital. Sorry for the mask, I'm in an office and we are quite a number. Yes.
Nice to see you.
Nice to see you too. So today we have a session and we're having participants from all over Kenya and they're interested in this topic today. So let's officially start the session. To the participants, thank you for logging in to today's sessions. We apologize, yesterday we didn't have a session, although we sent an email. We apologize for the inconvenience caused, and we hope that you'll accept our apology. Yes, all the people are saying, greeting us in the Q&A section. Thank you for greeting us. We are glad to see you here today. So today we have Professor Oppenheimer and Professor Fritz Dickmann. I really hope I've not butchered your names. Yes, and they'll be telling us about the management of renal patients in Spain, the experience they had, and we're excited to hear from you. Remember to put your questions in the Q&A section. We'll be able to address them after the presentation. So, Professor Oppenheimer, please go ahead and start the session.
So thank you, Dr. Kalonda, and thank you all for attending this meeting. It's for me really a pleasure to be in contact with you again with our Kenyatta friends and colleagues. And let me introduce Dr. Fritz Dickmann. Fritz is the chief of the renal transplant unit in my hospital, and he's also a German family name, both Oppenheimer and Dickmann, but doesn't matter. We are speaking from our position here in the hospital clinic in Barcelona, in Spain. And we have divided this conference in two parts. First of all, Fritz will speak about general questions about COVID disease. And later on, I will tell you our experience, our results in our renal transplant unit in general in the hospital. So please, Fritz, start with your presentation. I think that we need to keep some time for all the questions after the presentation or at the end of our both presentations, as the moderators will prefer. So thank you, Fritz. It's your time now.
Thank you very much. First of all, thank you very much for the invitation. It's an honor for me to share our and other people's experiences with you, and it's an honor for me to be in Kenya, although I'm not physically there. And I hope we'll have a very interesting session, and I hope we have a good interaction, although this is a telematic or virtual interaction. I will try to share my screen with you. Let me see. Okay, I'm still trying to share this with you. All right, here we go. Can you see my screen?
Yes, we can.
Okay, good. And you can hear me. Okay, so I will talk about a little about COVID-19 and the kidney, and I will try to give you some general ideas of what we've seen here in Spain, and then some general ideas about the about COVID and the kidney. What we know is that COVID-19 can cause acute kidney injury, totally independent of the situation of the patient. COVID-19 can actually cause acute kidney injury in patients who've never had kidney disease. And there are some interesting figures, and actually acute kidney injury has been seen in up to some reports 15% of all patients or even more, and including proteinuria has been seen in up to 2/3 of all patients that have been attended for kidney disease in different hospitals. And we know that acute kidney injury in COVID-19 patients is an independent risk factor for patient death. So this is a retrospective study that is about more than 300 patients with an mean age of 56 years, which corresponds more or less to the population that we've seen here also in our hospital. A lot of those patients had arterial hypertension. Some of them, almost 1/4, had diabetes mellitus, and the authors saw that actually 2/3 of those patients showed proteinuria, and even more than 40% had hematuria, and 10% of those patients presented actually acute kidney injury. Again, those were patients that not necessarily had known kidney disease before. And in critical patients and patients on the intensive care units, those figures were even higher. This is a study from New York, where they, in 13 hospitals in New York, more than 5,000 patients that have been hospitalized for COVID-19 were analyzed, and almost 2,000 of those patients presented actually acute kidney injury. And of those 5,500 patients that were hospitalized, 888 patients actually died. And if you look at the incidence of acute kidney injury and those patients who actually died, we can see that or that many patients who actually many patients of those who had died actually had acute kidney injury. We could say almost all of them. And those patients who were discharged and who had acute kidney injury at some point during the hospitalization had a creatinine of 1.7 at time of discharge. And this is again another graphic of those, and it shows you actually that if you have acute kidney injury in a severe stage, here this bar actually, then the risk of dying is more than 50%. And this is a work on on patients, 850 patients that were hospitalized. Another case series, 1/3 actually developed acute kidney injury, and more than 10% actually required dialysis. And again, those figures are higher in the ICU patients. What we don't know, of course, is what the long-term impact is. So what is the pathogenesis of kidney injury in COVID-19? We can say that the exact mechanisms still are unclear. What we know is what we've seen. We've seen patients with sepsis, we've seen patients with cytokine storm. We know that there is cellular injury actually due to the virus. We know that the receptor, the angiotensin converting receptors, are expressed in renal cells. That has been seen in MERS and SARS-1 actually, and we know that the viral RNA actually can penetrate kidney cells and can actually harm kidney tissue. And we've seen viral RNA in urine. I'm sorry about that. Okay. Another interesting mechanism seems to be like a Fanconi-like syndrome, and this has been seen in a work where they analyzed 42 patients. 28 of them were in the ICU, and 30 of those patients had at least 2 proximal tubal abnormalities, which we could call like an incomplete form of Fanconi syndrome. 88% had proteinuria, some had a renal phosphate leak or normoglycemic glycosuria. And all this was more frequent in the ICU patients, as we've seen in, in the other works. And this seems to be preceding the actually the clinical manifestation of the acute kidney injury. Some COVID patients also presented microangiopathy. We've seen increased myocardial injury, and actually parameters of myocardial injury in many hospitals are part of the evaluation of hospitalized patients. We've seen a state of hypercoagulability, and in our patients, actually, we've also seen patients with pulmonary embolisms in the context of COVID-19. Acute tubular necrosis, and in some few cases, cortical necrosis, and thus irreversible kidney injury has been seen in COVID-19 patients. And maybe the virus might target lymphocytes that also express ACE2, and this might also lead to a lymphocyte activation, and to activation-induced cell death, and thus lymphopenia, a clinical feature that we've seen in many patients. And procoagulation and complement pathways can actually activate each other. And interestingly, ACE2 is expressed in the kidney even more than in the lung, at least in the proximal tubular cells and in podocytes. There's emerging evidence of a pathology, a complex pathology that might be activated by the ACE2 receptor, and that this might be multi-organ. Actually, we've talked about the lymphopenia, we see cardiac and of course lung injury, and but we also see the muscular injury and acute kidney injury. There is a Spanish registry of COVID-19 patients that includes mainly patients on renal replacement therapy, so either on dialysis or transplanted patients. And here we see actually the data and the huge increase of numbers of affected patients during the months of March and April that unfortunately stabilized. And you can see here that most of the cases actually were diagnosed at the end of March and during the month of April. And you see here in red the number, the accumulated number or cumulative number of patient deaths. So there was a high incidence of patient death in those patients, and thus we can say that patients on renal replacement therapy seem to be in a very vulnerable population due to many different reasons, and I will try to talk about some of them right now. The clinical manifestations are the ones that you would expect: fever, respiratory symptoms, and but in some cases also gastrointestinal symptoms. The most frequent treatments in the months of March and April were at that time still hydroxychloroquine. We treated some patients with the antiviral lopinavir ritonavir. Steroids were used and other anti-inflammatory treatments as well, and some patients were even treated with interferon. So if we look at the populations that were entered in that registry, you can see that the dialysis patients were 10 years or 11 years older than the transplant patients. This corresponds to the population in Spain of patients who received renal replacement therapy. Interestingly, 2/3 of the patients that were diagnosed were male patients. Hospital admission was very frequent in those patients. ICU admission was also relatively frequent. Different treatments that we've already talked about. And then previous treatments, interestingly, patients with ACE inhibitors and angiotensin receptor blockers with an incidence that was the typical incidence in our patient population. But I can tell you that there was no negative effect of those treatments in this population that could have been detected in the registry. Patients were hospitalized for 10 or 11 days. And until there was a negative PCR, or until there was the patient was supposed to be cured. This was 15 or 13 days, and a relatively high mortality rate, 26% in dialysis patients and 20% in transplant patients in that registry. And factors associated with patient death in transplant patients was age, and if the patient had a pneumonia or not was a very decisive factor, actually. And this is typical for not only for patients on renal replacement therapy, but any other patient that was hospitalized for COVID-19. Okay, and this is the same factors associated with patient death in dialysis patients. Again, pneumonia seems to be the predominating factor. The patient evolution, again, in the overall population, 25% of patients actually died. And this is what happened with our activity of transplantation, of donation and transplantation during the pandemic. And here, if you see in January, February, this is the daily transplant activity, solid organ transplants, not only kidney. And you can see here the daily transplant activity, and this goes radically down at the end of March, and then at the end of April slowly increases the numbers. But I can tell you that we've not come back yet to the pre-pandemic numbers of transplants. If you look at kidney transplants here in green, you see the same scheme, and liver transplants were never really stopped because they were considered to be life-saving, and there was, except maybe for one day, there had always been some slight activity of liver transplants here in the country. So for recommendations for the transplant patients, I will just skip that slide because Dr. Oppenheimer will surely allude on that more in detail. And I would like to summarize that COVID-19 can lead to acute and maybe, and we don't know this yet, as well to chronic kidney injury. COVID-19 is associated with worse outcomes, and after respiratory distress, chronic kidney injury probably is a major risk factor that is associated with a worse prognosis and with patient mortality. The mechanisms of kidney injury are multifactorial, and we've seen that renal patients are at high risk of infection because at least dialysis patients, they need to go out, they need to go to the dialysis center, and of severe COVID disease in case of infection. And there had been a huge learning curve in Spain between the end of February or the beginning of March when we had our first patient. I think it was the first week of March that we actually diagnosed our first patient. And then 3 weeks later, our hospital was practically 90% filled with COVID-19 patients. And we've made a huge learning curve actually during that time. And we've dedicated 90% of the resources of the hospital to the combat against COVID-19 during that period, during March, the months of March and April. And for that, for example, the hospital actually doubled the number of intensive care unit beds, and we actually doubled the number of available respirators, and we introduced more intermediate care units, and we actually were lucky to medicalize a huge hotel here in Barcelona. A hotel with 350 beds was actually converted into a hospital with medical staff, with nursing staff, with laboratory, with a facility for doing radiologic imaging. And this was like an additional hospital, even with the possibility to apply oxygen therapy. And we were actually lucky to amplify or to increment our infrastructure in order to be able to to actually accommodate all those patients. And during since the beginning of the pandemic, we've treated more than 2,500 COVID-19 patients. And with that, I'd like to thank you for your attention, and I'm happy to take any questions. I don't know if right now or maybe later on at the end.
Thank you, Dr. Fritz, for your wonderful presentation. I think we can take questions at the end as we wait for Professor Oppenheimer to give us a presentation. I'd like to recognize Dr. Ngigi. Dr. Ngigi played a key role in organizing this team, the team from Spain, to come and share the experience with us. So Dr. Ngigi will be looking to you to add something once Professor Oppenheimer finishes with his presentation. Okay, Professor, go ahead.
So Dr. Ngigi, or just me directly?
Yes, that's it directly, and then now we
okay.
have Dr. Ngigi.
Sorry,
yes.
Okay, I didn't understand. So I will try to share my presentation with you. Okay, so first of all, I will introduce some data about the impact of the COVID infection in Spain. These are data from maybe yesterday. The total Spain is 45 million inhabitants. The impact of the number of infected citizens now is 313,000 cases, with more than 28,000 people died because of the virus infection. And here you can see the daily number of days in Spain, starting in early March. And during March and April, the number of deaths were very highly increasing until almost 900 deaths per day. And thereafter, there is a clear reduction in the number of the daily deaths. And now, within the last 2 weeks, the number of daily deaths is around 1 or 2, or maybe some days there are not any death at all. When we speak about patients with end-stage renal failure, treated end-stage renal failure, that means dialysis or kidney transplant recipients, the impact of the infection was quite similar in terms of the incidence, starting also in March. This in red you see the accumulative total of new cases, and in green you see the number of new cases that were detected in this population. And in your panel on the right, you see those patients that in red that died during this period of time. So more than 400 patients that would die. And in green, the number of patients that were discharged and cured. When we compared our Spanish population between dialysis patients and transplant patients, first of all, what we see is that we have registered more than 1,600 cases in total. 1/3 of them transplant recipients, and 2/3 of them dialysis patients. There are some differences between these two populations. The transplant recipients were younger. In both populations, predominantly male recipients, with the need of hospitalization more frequently in transplant recipients. And in terms of the pharmacotherapy management between the two groups, we see some few differences in the use of hydroxychloroquine, but both group of patients were treated in the majority of the cases with hydroxychloroquine, but more use of steroids in transplant recipients, and also more patients receiving tocilizumab. And also what we see a difference between the two populations is in the use of ACE2 receptor blockers. More patients in the transplant population were receiving these kinds of medication. And in terms of proportion of patients healing from the infection was slightly better in the transplant population, but in total, the proportion of patients dying because of the COVID infection was almost 27% in the dialysis population, 24% in the transplant population. When we analyze the factors that may influence those patients that cured from the infection and those who died, we see that death was more frequently in more elderly patients, no differences between genders, more diabetic patients in the group of the diet patients, and no differences in the proportion of patients according to the type of therapy, dialysis, hemodialysis, peritoneal dialysis, or kidney transplantation. Of course, those patients that developed pneumonia were showing an increased risk of death. And interestingly, those patients treated with Kaletra, lopinavir-ritonavir combination, or with higher dose of steroids also increase the risk of mortality, although this can have a bias in terms of the severity of the clinical picture, and is not really a direct effect of the medication used for these patients. And interestingly, those patients treated with ACE2 receptor blockers showed a potential benefit in this population. And this can be also seen when we specifically analyze the mortality associated factors in the transplant populations. We see that also age is a significant factor. In terms of patients developing abdominal manifestations seems to be protective. Of course, pneumonia is the most severe risk factors of dying. And again, the use of ACE2 receptor blockers seems to be beneficial in this group of transplant recipients. When we looked particularly in the experience in our hospital, here you have the picture of the number of patients that were daily admitted to our hospital since March 20. According to there were dialysis patients in blue, kidney transplant recipients in red, or patients from the nephrology clinic in yellow. And in green, you see the total number of patients that were daily admitted. So the maximum amount of daily admissions was observed in 11 April with 37 patients that were hospitalized in total in our hospital. And as you can see, there were, during some time, more kidney transplant recipients needing the admission to our hospital. When we analyze the mortality impact or the discharge rate, you see that in total, we experienced 24 deaths in our populations, and 49 patients that finally were cured from the infection. Here you see the differences in between the three group of patients. So infection was diagnosed in 37 dialysis patients, in 21 clinical nephrology patients, and in 31 kidney transplant recipients. These are patients that were directly admitted and treated in our hospitals, because of course there are also patients from our department that were admitted to other hospitals in Barcelona, or in the case of the renal transplant recipients, we have patients that are living outside from Barcelona, even outside from Catalonia. And from some of them, we have received information about their follow-up with the infection. But now I will speak about only about the results of those patients that were directly managed in our hospital. In terms of death rates, we see that 12 patients in the dialysis populations died. That means 34%, and this is more or less the same that in the Spanish population. 33% in the clinical nephrology department patients, and only 16.6% in our transplant population. That means 5 patients out of 31 that died during the admission for the COVID infection in my hospital. But as I previously mentioned, we have detected this infection not only in these 31 patients, but also in other at least 14 additional patients that were treated in other different hospitals or in other social residents, not really hospitals because of their medical or age conditions that didn't need the admission to their hospitals. So in total, 45 patients. We have done more than 4,000 transplants. We have recorded that today we have more than 2,400 patients with a functioning kidney, and we have only detected infection in these 45, but probably there are some few more additional cases that we have no information about them. So from these 31 patients that have been directly managed by our hospital, kidney transplant recipients, 26 required hospitalization, and 4 of them were treated at home. And in one case, the infection was diagnosed after the patient was cured. So this was a completely asymptomatic infection in this patient. And the first case that we have confirmed with PCR in our patient was the 3rd of March, 220. So since 3 of March, okay? In this slide, you can see the patient characteristics. First of all, the gender distribution, 62% of men, transplant men, and 38% women. According to the age, the mean age was 59, and the range was between 33 and 89. We have no one case of patients below 30, although of course our population below 30 is quite low because this is an adult transplant unit. So the majority of the patients that are transplanted are over 18, and during the follow-up they are now over 20 or 25, of course. But only 3 cases of patients between 30, 39, and very interestingly, 13 patients in the group of patients between 40, 49. But the majority of the patients that were infected were older than 50, and the majority of them also older than 60. So 59 is the mean age. According to the transplant type, the majority of them, of course, are kidney transplant recipients. In 2 cases, there were recipients from a combined kidney pancreas or a pancreas after kidney. 1 case was an isolated transplant, pancreas transplant that was treated in a different institution. 1 liver kidney transplant and 1 kidney heart transplant also. And according to the blood group distribution, we have seen 42% patients from blood group O, 40% from blood group A, 13% blood group B, and 40.4% blood group AB. And this is approximately the same distribution or the same proportion as in the transplant population, the distribution of the blood groups. So we have not seen any negative impact of the blood group A in terms of the incidence of the COVID infection in our transplant population. According to the time after transplantation where the infection has appeared, we have seen out of these 45 patients, in 7 cases, the infection has happened within the first year after transplantation, 7 cases, none of them before 3 to 4 months after the transplantation. So none immediately recently transplant were infected at all. So after the first year, we see 4, 3, 2 cases for patients with additional follow-up after transplantation. And for very late transplants, we have seen so very few cases. Only, very interestingly, 3 cases in patients with follow-up after transplantation for more than 20 years. 3 cases. In those patients that were diagnosed and treated directly in my hospital, these 31 patients, we saw, as I previously mentioned, that the first case was diagnosed in early March. The consecutive cases that we saw were some days later, since March 13, and since that date we saw almost daily 1 or 2 daily new cases that were admitted to the hospital, with a peak of cases in 26th of March. Then was a reduction in the number of cases, and there was a progressive and finally a withdrawal of new cases after the end of April. So after April 29, we have not seen any new additional case. So this incidence profile curve is very similar to what has been seen in the normal population. However, I must tell you that now in July, in Spain, specifically in Barcelona also, there is a rebound of number of cases infected in the normal population. But since this moment, we have not seen, or at this moment, we have not seen any additional transplant new case. And this means that probably now the patient have adopted more strict preventive rules in the transplant population. The confination is more strictly being done than what it probably was done within this initial period, where many of the patients were not really aware about the magnitude of the pandemic. And probably this is explaining why this quite high incidence in the beginning. In terms of the patient characteristics that were admitted to our hospital, first of all, the initial clinical picture from the 31 patients that we managed directly. In 5 cases, the patient developed only a viral syndrome with no one other clinical manifestations or complications. But the majority of the patients, in 18 cases, started with a viral syndrome that was immediately followed after some days by the diagnosis of pneumonia. So this was the most characteristic clinical picture in our patients. And in 8 out of the 31 cases, the patients at admission were presented directly with pneumonia. When we review the symptoms of these patients, the majority of them, almost all of them, presented fever. Many of them also cough. Some of them dyspnea, probably those with pneumonia as the initial symptoms. Some of them, 1/3 of them, with abdominal symptoms too. Headache was also present in some cases, and also some odynophagia or loss of smell in some cases, not as many as it was seen in the normal population. In terms of the baseline immunosuppression in these patients, in order to try to find out any potential risk factor of the baseline immunosuppression, the majority of the patients received tacrolimus. Also, more than 2/3 of them mycophenolates, 1/3 everolimus or sirolimus, 2/3 steroids, baseline steroids, and 1 case also was treated with eculizumab. So many of these patients were receiving a combination of these drugs, tacrolimus in combination with mycophenolate, or tacrolimus in combination with everolimus or sirolimus, and the majority of them also associating prednisone too. When we analyze the management of these patients in our hospital, from the pharmacotherapy point of view, first of all, what we did in the majority of cases was stopping the immunosuppression. Of course, always stopping MPA or mTOR inhibitors. In many of the patients, and in the majority of them, also we stopped tacrolimus since the beginning or after introducing the Kaletra therapy because of the intense pharmacokinetic interaction between the 2 drugs. But in some cases, where patients that were with mild symptoms or were not receiving Kaletra at all, they were remaining on low doses of tacrolimus. After the recovery of the infection, we restarted in all of the cases the CNI therapy, and more later in the time, in some cases with very prudence, we restarted with MPAs, and in no case we started with mTOR inhibitors in order in this initial period to avoid the potential toxic effects on the lungs in these patients. With regard to the steroids therapy, in all the cases, or in the majority of the cases, we increased the baseline dose. There was a steroid dose intensification from 5 to 10 to 20 milligrams in the majority of the cases. And we will see later on that we also needed in some cases to give steroid pulses as an anti-inflammatory effect. In 8 out of these 31 patients, we need to admit the patient to a intensive or a semi-intensive care unit in 8 cases. In 3 out of these cases, that was the need of intubation and mechanical ventilation also. And in 4 of the patients, there was a need of dialysis support during this meantime. One of these 31 patients, the infection was discovered or diagnosed 2 to 3 weeks after restarting dialysis because of failure of the previous graft. So this patient was an additional case of graft failure, but this was not a case because of the infection, but after the infection came after the graft failure. In terms of the pharmacotherapy of the infection, as I've previously mentioned, some patients needed additional steroid bolus to improve the anti-inflammatory effect. Hydroxychloroquine was done in the majority of the patients, also azithromycin, and also in the majority of the patients, Caletra was given in these patients, and the majority of the patients were receiving hydroxychloroquine with azithromycin and Caletra. This is in the majority of the patients. In 2/3 of the patients, tocilizumab was administered when the inflammation signs, especially pulmonary inflammation signs, started in order to reduce this negative effect of the cytokine release syndrome. And so 18 cases with tocilizumab and in 5 cases with anakinra, an anti-AL1 receptor blocker. 2 patients were treated with interferon beta, and 1 patient with baricitinib, inhibitor of JAK1 receptor. And 1 patient, this patient with asymptomatic infection, there was not kind of therapy administered. So in 80% of the patients, in 25 patients, there was administered a combination of azithromycin, hydroxychloroquine, and Caletra. In terms of the outcome, first of all, hospitalization length was, the mean length was of 3 weeks, ranging from 9 days to 2 months. Acute kidney injury was present in 58% of the patients. These are the baseline serum creatinines and GFRs before the infection. And as you can see, mean serum creatinine ranged from 1.7 to 2.7, and the mean estimated GFR from 46 decreased to 34. And during this period of time, the two patients needed, lost the graft, so they didn't recover after the dialysis support that was introduced during this period. And finally, 5 patients out of these 31 unfortunately died. This represents 16% of our patients. This is lower than in the general dialysis population, of course, lower than in other hospital experience in transplant recipients in Spain or in other countries too. And of course, even lower than in the normal population in Spain. When we see the outcome, not only of this 31, but also the 14 additional patients from our transplant unit that were treated in other institutions, we have noticed for also 3 additional deaths. So in total, we have 8 out of 45 patients dying. This represents around 18% of deaths. And in the last weeks, we have no information about any other deaths in our patient population. When we look to the age of the patient that died, we see that except 2 of patients with 55 or even 65, all the other patients were older than 65. In one case, 89, and most of them older than 60. So one of the predominant factors in these patients that died was they were quite elderly. And this is the information that I already prepared for you. So I finish here my presentation, and of course we will happy to hear from you, your comments and your questions. Thank you.
Thank you so much, Professor Oppenheimer, for that wonderful presentation and for the clear demonstration of the graphs and also the statistics. We would love to hear from Dr. Ngigi on the Kenyan picture. So Dr. Ngigi, kindly make a comment, and let's see whether we are in the same picture as the Spain picture.
Thank you very much, Rhoda, and good afternoon, everyone. That was very impressive presentation by Dr. Dickman and Professor Oppenheimer, who have really shown us how they have managed this condition in Spain. In Kenya, we are also having our own challenges. Of course, the number of patients who are coming up with COVID-19 continues increasing. And we know numbers, patients have not been spared in this. We are getting quite a number of patients with acute kidney injury presenting to us, either because they have got acute kidney injury due to other reasons, but then we diagnose COVID. We may also be having some patients who have got COVID-19 related acute kidney injury. When we look at the demand, looking at the demand for services related to COVID-19, we are getting a challenge because of the increased number of dialysis requirement for dialysis machines, particularly in the epicenter areas like Nairobi. We are also requiring more trained personnel who can deal with the upsurge in numbers of patients who need dialysis. But what is probably more challenging is the ability, our testing ability, the fact that our COVID-19 PCR results take a bit of time, and this can pose a challenge in care because we are putting patients now, for example, in the waiting suspect scenario, and this, of course, is a challenge. But looking at other issues, our preventive nephrology has suffered quite significantly because the patients who were following up earlier no longer comes to the clinic, or rather the clinics have been slow, but now we are slowly opening up. When we look at the policies that we have set in place, the Kenya Renal Association and the AFRAN have come up with robust policies of managing COVID-19, and these have been very helpful, particularly in preventing nosocomial infection, because our patients, just like in other parts of the world, come every day. And we are getting very many patients now who have got chronic kidney disease and indeed on dialysis who are now being diagnosed with COVID. So the policies that we put in are going to be helpful in coming days because they will assist or they will prevent in patients getting more exposed, and also our staff. Regarding kidney transplantation, we still have not opened our transplantation programs in the country, but we still continue taking care of our transplant patients who we transplanted earlier. We have gotten like 4 or 5 patients who have been reported to have had COVID post-transplant. One of them required intensive care support for a month, but luckily, following the guidelines that have been put in place by AFRAN and the ISN, and indeed what Professor Oppenheimer has said, we have seen these patients come out of the COVID situation. But by and large, when you look at our transplant follow-up, we are still doing a scientific or virtual follow-up using Zooms and other platforms. But we are slowly opening up the post-transplant clinics and restricting numbers to like 10 or 15 every other week, and encouraging those patients who must come to hospitals to come. We are going to see, or we are also seeing unusual presentation of patients who normally would have presented with nephrotic syndrome in the usual way, but now we are getting many of them coming in with permanent thromboembolisms. A few patients, 2 patients have been reported to get renal vein thrombosis outside the traditional membranous disease, which means that perhaps, and these patients have also had COVID, which means that we may attribute this presentation of thrombosis with the COVID. So we are getting these challenges just like the rest of the world. And we are happy when we share so that we learn more and hope that what we get out of this will be interpreted into improved outcomes of our patients. Thank you.
Thank you so much, Dr. Ngigi. And yes, I agree. We are learning so that we can have improved outcomes of our patients, and we can also see how other colleagues from other areas were able to manage their patients better. Thank you so much for those comments, Dr. Ngigi. We appreciate. And I also echo your sentiments that we need more machines, we need more specialized personnel, and we also need to encourage our patients to come back for their clinic visits to seek care wherever they are. They need to come back and continue with their usual clinic so that we don't lose them in the process. And we also need to there's increased demand. We need to create space infrastructure. We've seen very nicely and clearly from what Dr. Dickman told us, that the hotel that was converted into a hospital, they had infrastructure that was able to manage and handle 2,500 COVID-19 patients in his facility. So that is a learning point. The fact that the system can adapt to and change very fast in the shortest time possible to improve patient outcomes is something that we need to adopt and see how best to bring it into our system, into the Kenyan system. Good. So I'm seeing a few questions in the Q&A section. I hope Dr. Dickman and Professor Oppenheimer, you've had an opportunity to go through them, and also the comments where people are appreciating the conversation. I have a question. Before we go to the Q&A, I have a question. You briefly mentioned, talked about the reinfection rates that you're now starting to see. Do you have any statistics on how many patients have come back to either of your facilities who had recovered and had been discharged? Patients who were undergoing dialysis or under kidney, who had undergone kidney transplant have come back with reinfection of the COVID-19 disease from the time you discharged them. Do you have that data, Dr. Dickman?
I'm not sure if I really understand the question. Those patients who were transplanted recently and then came back with the disease, or
the patients who were discharged? You discharged 3,280 patients.
But patient discharge for COVID, not
yes.
necessarily transplant patients. Okay.
Yes. So I'm specifically asking about the patients who underwent dialysis and who had been undergoing dialysis and who had had renal transplant. Have you seen any reinfection rates in them? Have they come back with a reinfection?
Well, we have not seen second COVID infections. If that is the question. There were some doubts, or we had some doubts with prolonged positivity of the PCR. So especially in dialysis patients that need to be checked, or we needed, for example, in order for the dialysis patients to go back to their usual dialysis units, we needed, of course, absence of symptoms, and we needed 2 repetitive negative PCRs. And we had seen positivity of PCRs during the time when the patients were already free of symptoms. But we did not interpret this as a reinfection. Have we had a patient who had diagnosed COVID-19 treatment, have been hospitalized, then gone home asymptomatic, and then come back with another COVID-19 infection? The answer is clearly no.
Okay, thank you. Yes, Professor Oppenheimer, have you seen a second infection in these patients?
No, you mean no rebound? In fact, we are treating the same group of patients, so no rebounds, but certainly some patients where the clearance of the viral load was more slower than in the general population, and also the detection of positive IgG or IgM sometimes came later than in other populations, but the few number of cases make it difficult to make a really assessment of this point.
Okay, thank you for that. Now going to the Q&A section, we've seen a question from Julieta Wairimu, and she's wondering about the blood group. So she's just saying, thank you for the informative session. It's keeping us informed and we appreciate. Just wondering why there's a high number of infected patients in blood group A and O and less in A, B, and B. We had 42% of patients in blood group O infected, 40% in blood group A, 4.4%, and 13.3% in A, B, and B respectively. So is there any explanation that we might have with regards to that, to the blood group and infections?
So thank you for the question. No, in fact, the distribution of the blood group types in the infected population is quite parallel to the distribution in the normal population in the transplant population. So our 40% of the patients are blood group O or blood group A, and less than these are B or AB, of course. So there is no importantly, there is no difference according to the blood group in terms of the incidence of infection.
Okay, thank you. And there's another question from Marie, and she's asking, for patients who you continue with tacrolimus, you reduce the dose, what % did you reduce the dose by? And did you have the targeted tacrolimus levels you're aiming for?
Fritz?
Well, we in our patients, we actually, due to treatment with either interaction with treatments with lopinavir and ritonavir, or severity of disease, we basically stopped tacrolimus in almost all of the hospitalized patients. So therefore, there was no real trough level. What the general recommendation is in those patients where you have a mild clinical course of the disease and that might not require hospitalization, then you could actually maintain the tacrolimus with maybe a lower trough level and increase the steroids and withdraw the concomitant anti-proliferative treatment. That is one of the recommendations for patients with a very light course of the disease. However, in our experience, we basically withdraw the anti-calcineurin inhibitor in all of those patients. So there's no real practical experience from our own patient series. Maybe Dr. Oppenheimer, you would like to add something?
No, that's really the case. But because many of our patients were receiving also Kaletra, and with this intense pharmacokinetic interaction, so the problem was this interaction, not only our idea or our aim of trying to find out a specific level range. So many of the patients, the tacrolimus was stopped or was reduced to very, very, very low doses because of this intensive interaction.
Okay, thank you for that. There's a question from Joel, and is asking whether you performed any kidney transplants in a bid to manage COVID-19 or otherwise. So did you have any surgeries during that time, kidney transplant?
Well, we stopped the transplant activity, or we performed our last kidney transplant 2 days before actually the lockdown, or the week before the lockdown, might have been 3 or 4 days. And then we did not resume the activity for 6 weeks. So so the last transplant was on the second week of March, and the first transplant again was on the 27th of April, which was a cadaveric donor kidney transplant that went well. We had stopped the transplant activity for 2 reasons. The first one was that the hospital was just not able to dedicate resources like intensive care unit beds, operating theaters for kidney transplant activity, since we didn't consider the kidney transplant activity like an immediately life-saving procedures. The hospital still went on doing heart transplants and liver transplants, for example. And then the second reason, beyond the resources, was that we were not sure what was the risk of recently transplanted patients actually to be infected with the virus, or during the hospital stay, or in the immediate postoperative care phase, when the patient needs to come to the hospital relatively often to do blood analyses or image analyses. And we just felt at that time we're not sure that we could actually guarantee a COVID-19 free environment to those patients. We needed those 6 weeks in order to implement those safe circuits. And that's when we actually started again. And that's just coincides with the reduction of the case numbers.
Okay, thank you. Would you like to add anything to that, Professor Oppenheimer? And as you add, part of the clinical management the first thing he said is that we stop immunosuppressants, especially MPA. And Marie is asking, after how long do we reintroduce MPA back to the patients?
Okay, thank you for the question. This is important because nobody knows exactly when we are able safely to put the patient in a normal immunosuppression therapy at all. And of course, the first point is we have to individualize because there are different patients and different follow-ups or different complications during the admission. There are patients that are discharged quite sick, that need a convalescence, a more prolonged convalescence. And of course, in this patient, we must to be very cautious in the intensification of the immunosuppression. For those that are completely restored, I would say that at least 1 month after the first visit, without introduction in additional medications, only steroids and probably tacrolimus. After 1 month and checking that everything remains okay, me personally, I would be considering to reintroduce MPA, but this is something very personal and nobody knows exactly how to proceed.
Okay. Thank you for that very honest answer, Professor Oppenheimer. And there's a question from Sophia, and Sophia was asking whether you found any virus in the urine, SARS-CoV-2 virus in the urine samples of your patient, and is there any correlation with worse outcomes?
As far as I know, we have no checked virus in the urine. Fritz, you?
Yeah, no, we didn't look for it. We didn't look for virus in the urine, and interestingly, the virus from its size should not pass the glomerular barrier in a healthy kidney. And I cannot tell you about SARS-CoV-2, but we know that from SARS-CoV-1 that there was virus in the kidney in biopsies or in necropsies and autopsies, but I'm not aware of any biopsy report or any published report in biopsies, in kidney biopsies in living persons with virus in the tissue. So there might be a difference in those who actually died and had severe kidney injury. But we know it. I think I'm recalling an article in pediatric patients that virus PCR was positive during a long time in urine, which I have no explanation for, but we don't think that urine or maybe semen might transmit actually active and infectious virus.
Okay, thank you for that. Now, in your presentation, Professor Oppenheimer, you said 80% of your patients, you get them azithromycin, hydroxychloroquine, and Kaletra. Now, seeing that we are currently having, of late, we're having FDA cautioning us about use of hydroxychloroquine, what regimen are your patients currently on, if you have any patients who are still admitted in your facility, and what would you advise us to put our patients on back here at home?
No, thank you. Yes, now we have no patients admitted at the hospital. And of course, the hospital protocol is changing according to the new information that we have. And we are expecting what our colleagues from the infection service are establishing for the new cases in order to avoid the use of azithromycin or hydroxychloroquine and so on. But now we have no case that we can explain you that we have used a different therapy. I can remember that the last cases that we admitted to the hospital late April, some of them were not treated with this combination at all, because that was seen at the time that this is not useful at all.
The hospital treatment protocol actually during sometimes changed every other day. And as we gain new knowledge, we adjusted the treatment protocol. And in some patients within clinical studies and or as compassionate use, we did use remdesivir as direct antiviral treatment. But there might be a restriction in terms of kidney function, because the recommendation is not to use it in patients who have GFR less than 30. So this is not the rule. This is more the exception.
Okay, thank you. And you actually had very good outcomes. Your patient management was very impressive. You had recovery rate of 68.8% in your dialysis patients and 72.7% in your transplant patients. That was really, really impressive. You did a very good job, as much as you lost a few patients, but you did well. For our patients, and I can see from your patient characteristics, most of the patients who got infected are patients who were within 1 year, 1 to 5 years post-transplant. Other than the behavioral measures that have been put in place, social distance, wash your hands, wear your face mask, is there any medication or any particular diet that we could prescribe to these high-risk patients so that we can protect them and keep them a bit safer now that we might not have the infrastructure to manage all of them at the same time? If they come 37 at the same time, as we saw at one point, you had 37 patients at the same time, we may not be in a position to manage those high numbers. So how do we keep these patients a bit more safe for longer?
Fritz?
I think there's the only answer is to prevent the infection, and we need to implement all possible measures that our patients are not infected. And unfortunately, the only measures that we have so far are the ones that we've always used. That is actually confinement, social distancing, face masks, and avoiding contact with other potentially infected persons. That's so far the only thing that we can do to prevent the infection. I'm not aware of any measures in terms of diet that actually reduces the number of infections or that helps cure the infection. So I'm not aware of any data about that.
Okay. And any pharmacotherapy? Any medication you might have used on your patients?
Preventive medication. We have not used any preventive medication in our patients, and it probably, if you look at our numbers overall, the risk of infection in our patients was relatively low. And since our patients are well trained in confinement, because it's due to any other disease or flu, or our patients probably tend to have lower infection rates than the general population. So to do a general treatment for maybe 2% of the patients, treat 100%, probably is not a rational strategy right now.
Okay. Thank you for that. There's a question from Marie, and we see your graft loss during admission. You only had 2 patients who had graft loss. So Marie is asking, what explains your low rates of graft loss despite stopping the immunosuppressants?
At this moment, we have no answer to that. No, because we don't know the exact impact of the temporal withdrawal of the immunosuppression that can have in the long run, or even the impact of the infection in the immunological status of our patients. So, but at this moment, the two cases that lost the graft, one of them had previously chronic renal dysfunction with a low GFR. The other one presented an external renal function, but after this acute kidney injury and also the comorbidities and complications that may appear during the admissions have contributed to the loss of the graft. What will happen after that? We need more time to analyze what is the renal function. The majority of our patients are recovering the renal function almost to the pre-infection situation. But we have no data from all the patients now.
Interesting. Thank you so much for that. As we finalize, almost ending our session, I'd like to get the participants who raised their hands. You can unmute yourself and ask your question or share your comment. And before we end the session. So Diana Cheng, go ahead. We have Diana Cheng, Paula Cherono, and Saif Muindi. You can unmute yourself and ask your question if you've raised your hand. All right. So as we wait for any of the participants who would like to ask a question, there's a question from Barry Ayumba, and he's asking whether you vaccinate, whether you're giving any vaccination to your patients. And he's also asking how or what is the timing. I'm not sure I understand. Yes.
There is a pre-transplant vaccination protocol for our patients that is established, and we send the patients to the preventive medicine department in our hospital. They evaluate all the immuno status of the patients and all the vaccines that should be re-administered or de novo administered in case they were not previously vaccinated. And we vaccinate against the majority of the normal viruses before the transplantation: hepatitis B, varicella zoster, meningitis, all the standard vaccines. After transplantation, this is more difficult to do because of the low efficacy of the vaccinations. And we, in fact, only are insisting in vaccinating patients that will need therapy with eculizumab, but this is a very low proportion of our patients. Okay. Of course, for flu, we vaccinate, or we recommend to vaccinate every year our patients, of course. Sorry.
Okay. Thank you. Thank you for that response, Professor Oppenheimer. I see it's time. So I'd like to thank Dr. Fitz-Dickman and Professor Frederick Oppenheimer. I'd also like to thank Dr. Ngigi. Thank you all for finding time and coming to share your experience. Dr. Ngigi, thank you for organizing this session with the team from Spain. We've learned quite a lot from them, and we're encouraged from their presentation. Out of 313 patients who tested positive for COVID-19, they only had 28,000 of them, or approximately 28,000 of them who passed on. It is an encouraging thing for us as we are starting to see our numbers rise. Thank you so much for taking time. We are also learning that some of the risk factors, and we need to protect our patients, especially the high-risk patients. We still, I don't know if anyone already has the answer why we're having more men infected than women, but it's a global picture. It's the same picture we are seeing here in Kenya. We would love to know. I've also seen somebody asking that in the Q&A section. It's a very interesting perspective that we'd love to understand and see. We would be glad to also get the Kenyan picture at one point and see whether the patient characteristics are similar to your patient characteristics. But thank you for that presentation. Thank you for taking time and preparing and also coming to talk to us. Thank you very much.
Thank you very much.
Thank you.
Thank you very much. A great
Very
pleasure.
happy to contact you.
Thank you.
Thank you. Bye
Thank
bye.
you. Bye-bye.
Bye-bye.
Bye bye.
Thank you. Dr.
Bye.
Ngigi,
Thank
Dr.
you.
Ngigi, thank you for organizing this session. We are looking forward to learning more about from other countries and share experiences. So if you can be able to organize another one, so that we learn, the more we learn, the more we understand and the less the fear. So thank you so much, Dr. Ngigi, for organizing this for us.
Welcome and thank you.
All right, thank you. To the other participants, seeing a few concerns about CPD points. I hope for the team from PPB, your concerns have been addressed. If they've not, we will link up with our pharmacy team and find out how to address them. For Frederick Odira, I see you mentioned about not getting your points from Dr. Online. Mr. Mwenda will follow up on that and we'll be able to give you feedback. Anyone else who's having challenges with Dr. Online, kindly let us know. But so far, that is the only complaint we've received. We will follow up, Fred Odira. We did not ignore your question. Yes, so thank you all for attending this session. We look forward to seeing you tomorrow. Tomorrow we'll be having mental health Thursday. So we look forward to seeing you tomorrow. Bye.